Thank you, Dr. Ichi, for your kind introductions. Yes, remind me of 1985, 40 years since I graduated. So with that, I'm very humble and to get invited and to share my knowledge and the experience to all the GP in Myanmar and for future generations. Appreciate it. Since about 40 years already now, so with that, I'd like to give my gratitude to my all teachers in the past, who has been passed away, like Xiaoyu Mamon Singh, Xiaoyu Somian, Dr. Maji, Dr. Ju, etc. And some of my teachers are still alive, Xiaoyu Myo Tue, Xiaoyu Mamon Yo, Xiaoyu Nyan Thing, Wimya, Dr. Maung, etc. Okay, so I may not count everybody, but this is kind of I respect and give gratitude to all my teachers. All right. I choose these topics because of that Dr. Wim Yang told me that he gave the lecture on the palliative care in the past, so that I just don't want to repeat it. So this will be a little bit more applicable to your clinical practice. So like more practical stuff that how to assess the patient who's appropriate for hospice care, how to care for the end of life. Okay, so that's the reason that I choose these topics. So kind of combined with the two lecture from my curriculum in the University of Miami Hospital, and then kind of the prognostications and the kind of end of life care. Okay, so the first portion I'm going to be talking about the prognostications for the who's going to be appropriate for palliative care, who's going to be appropriate for hospice care. So then going to be moved towards the end of life care in the hospice setting. Okay. So let me see. Hold on. I have no disclosure. These are the learning objective. So to discuss the steps in the prognostications and the determining hospice appropriateness in the advanced illness, either cancer or non-cancer diagnoses. And also we want to talk about the skill in the managing dying patients and how to coach the family. And also the clinical dilemma in the end of life setting. Okay, these are the three main objectives. Okay, so so you probably know that hospice and palliative care is different. Okay, so the palliative care start with the palliative care you can see as the big umbrella. So really to the end of life, which is called hospice care, right? So the palliative care deal with the you can call it palliative care, the doctors for the seriously ill patient. That you can say that, right? So we're kind of providing specialized medical approach that can be done at any point in the illness. Doesn't have to be, to determine by prognosis, okay? And also, depends on the needs that, patient or family may have. So we also give the palliative care treatment like pain symptom management, other support, along with the life prolonging treatments, okay? Even curative treatment as well. And we try to help with the pain symptoms, stress of the illness. And we try to empower the patient, the families, give the extra support to the primary team to help manage navigating the patient care, right? Hospice care is kind of more as the end of life, really less than 6 months or less, like life expectancy to live. We call it terminal diagnosis. So you can provide with the curative treatment is no longer appropriate or beneficial. Some people focus on the end of life care. That's the time that hospice is appropriate. Okay, so the main goal is to manage the symptoms, relieve the suffering in the final months, and we provide the care with the interdisciplinary team members, which is social work, psychologists, recreation therapists, physical therapists, you name it. So a lot of the team is involved with hospice care, right? So you see in the end, like hospice in the US, we call it hospice, Medicare hospice benefit. I'm going to come to that a little bit later, explain to you, okay? And then when you get to that point, hospice will take over the end of life care. So in order to be hospice eligible, I try to use the two terminologies. One is the hospice appropriateness, and the other one is hospice eligibility. There's a two different meanings. Okay, so to become hospice eligible, the number one thing, you got to be certified to have the patient have the terminally ill. Okay, usually done by the two physicians, either by primary team or palliative physicians or any the specialists. They can say that patient is hospice appropriate. Okay, so one of the one of the verbiage that we use is when so and so patient is deemed terminally ill, secondary to the sudden the terminal diagnosis with the prognosis of 6 months or less to live if disease run is normal course. That's a kind of the standardized the description of these hospice terminal status. Okay, and the number two requirement is the comfort care goals, which mean that patients total focus is to the just to make him comfortable, not to get more treatment to curative treatments, anything like that. So we cannot stop curative treatment, okay, for the terminal diagnosis, okay. And number three is election of hospice care. So in Medicare hospice benefit, patients who choose either curative care or the hospice care. So Medicare Part A. So you have to choose one of those. So if you choose hospice care, you cannot choose the curative care anymore for the terminal diagnosis. So you need to have all three requirement to be hospice eligible in the United States. Okay. Sometimes patients say that, well, I know I'm terminally ill. I just want to be comfortable, but I don't want to get hospice care. Then you can not be refer that patient to the hospice agency. Okay, so that is kind of the requirement. So we usually say that terminal stage is usually defined by that 6 months or less to live. Okay, so which is very arbitrary. So that started with the Medicare hospice benefit, which since 1983, somewhere around, that's when the law passed, the Medicare hospice benefit. So they have to pick some number. So they pick the 6 months or less to live. Usually, which is done by the cancer prognosis. That was that time, hospice, 6 months or less was started, right? So very uncertain. Okay, so inherent uncertainty, to do with that, we're not really sure, 6 months is a bit too long to predict that much with certainty, right? So so prognostication is usually we talk about the advanced illness. Not that somebody come to the hospital for pneumonia, you get better, nothing like that. We're talking about the advanced illness, either cancer or non-cancer diagnosis, right? So the prognosis is kind of tricky, we always learn in medical school and anywhere else in training, we learn to assess a patient by system-based, which is kind of cardiology or pulmonary, GI, kind of the system-based assessment, right? So we fail to look at the whole pictures, which is kind of the more domain-based assessment, which kind of the medical domain, psychological domain, functional domain, social domain, and spiritual domain. So which is a little bit more broader sense that how you assess in the in the geriatric and palliative care, right? So that reflect me also that when I was after finished my my residency, I was already practicing the internal medicines, but when I went to the practice, there was the last, the 2003, 2003, somewhere around. So I did some home care when the VA, so home-based primary care. So I have some, incident really telling me my deficiency about, something that I don't really aware of it, or I don't know that I have a deficiency. So I take care of one of the elderly couple. So the patient with a stroke, the wife is a nurse, used to be a nurse, retired nurse. So the patient was totally bedbound, total care. So I wasn't really know that patient going to be dying that quickly. So she was kind of guiding me, though, patients kind of declining over time. So I wasn't really aware of that. So that really opened my eyes that, how to, how deficient I are. I was that time, to recognize that, dying process is coming, right? So another incident was that, full blown CHF, patients really already have, take out the fluid, patient going to get better, but patient die anyway, so in the hospital. So really, really struck me that what I need to get more training. Okay, so that time the training was kind of very early. I was the second class in that fellowship during that time. So kind of that really opened me up, to get the additional training in the so in palliative care, there's a three skill that is really needed to practice. Okay, number one is the pain symptom management. Okay, so the number two is the prognostications, which is letting what they give you the guidance of the how to navigate the the advanced illnesses, which where to go, what kind of treatment you're going to be withhold, what treatment you be continue, kind of thing. So that really need to know that prognosis is very important. And also another skill is the communication skills, which is three main core skill that you needed to practice palliative medicines. Okay, so the prognostication is either out of how you're going to say that as out of science. So it's kind of both. Okay, so it it is some subjective component as well as some objective. The data that you're going to rely on. Okay. So when you talk about the prognostications, there's a three major component. Number one is the formulation of the prognosis, which is kind of the foreseeing. That's how we call it, right? So the which to do with a lot of the homework that you have to do. Meaning that let's say you have to really dig into the patient histories. For example, patients with prostate cancer, you want to know how aggressive the cancer is, like Gleason scores, PSA levels, and the diagnosis, metastatic disease, disease response to the treatment or not, recurrence diseases kind of thing. So you're going to really look into the objective finding of that what happened and in the clinical course, and then you kind of predict for the future. I mean, what can happen in the next few months or years. Okay, so that is the kind of your objective formulation of the prognosis, right? So number two is the estimation prognosis, which is kind of focusing, like weather focus, what will happen next 2 days, what will happen next week, kind of thing, right? So that is kind of focusing. You give the prognosis in terms of time frame. Okay, so so what can be expected clinical course or complication can happen, and the patient may decline and the maybe end of life. Okay. Number three is that how to communicate to the patient, the family, which is called foretelling. Okay, so kind of the predicting that you're going to talk to the patients and the family, what will happen, how much time may you have left, which is kind of the communicating the prognosis. All right, these are the skills that you needed in the palliative medicine. So a lot of the literature in the prognosis start with the cancer prognosis. So the many of the non-cancer prognosis also, we kind of, get get it from the cancer prognostications. So these are the kind of the indicator that we look at when patient's terminally ill or not. Okay, so the number one is the performance status, which is kind of the global assessment of the patient functions, which is different from the ADLs, IADL. You probably know the ADLs is kind of the activity of daily living, and the IADLs instrumental daily living. So it's kind of different from that, kind of the more global assessment of the patient functions. Okay. Number two is the clinical physician clinical prediction survivor, CPS. That's how we call it. So kind of very subjective. There'll be a lot of bias. You have to look at the patient, kind of more to do with the experience. Okay, so how you see the patient, right? Number three is the physical sign and symptoms, and the other psychological factors, what can be influencing the patient prognosis, right? Other one maybe kind of biological factors. These are the kind of the more or less, the indicator that we look at in the terminal cancer patients. So this is a performance status. You probably heard about the KPS, which is the Karnofsky performance status, which is since 1949, like more than 75 years old. Okay, so the if you look at here, 0% being dead and 100% being normal. So kind of the each 10 scales and double, so that would be kind of there's a description, right? So at that time, they use the mustard agents for the as a chemotherapy. Actually, less than 50%, they don't provide any cancer treatment anymore at that time. Okay, so the later on, they use that EGOG. If someone work with the oncologist, you might be heard about this EGOG. Okay, so EGOG is the opposite from that KPS, 0% being normal and 5% being dead. Okay, so the so more than three or more is kind of the kind of comparable to the less than 50% of KPS. Okay, so if you look at the description here, that the one of the keywords here, the more than 50% of the waking hours, which is the patient's okay, able to move around. So the EGOG 3 or more is kind of the more than 50% of the waking hours. They are confined to the bed or chair. So they have very limited functional capacities. Okay. So if you 4, you're pretty, very bad already. Okay. So the 3 or more is very, we don't give the chemotherapy anymore at that time. No more research study going on for that. Okay. So this is kind of the very focus on the cancer prognosis. Okay. So another one that we use here is a PPS, which is the Palliative Performance Scales, which came out in 1993. Kind of a little bit, they kind of modify from that KPS, but they kind of a bit more systematic. The 5 columns: ambulations, disease activities, self-care, intake, and the conscious level. Right. So what you do is 10% increment. So you start from the top to bottom. The left column is more weight to the determinations, right? So top to bottom, you start from the top. You stop where the patient fit the best. Let's say patient fit reduce. If it's too reduce, you pick whatever the patient fit the best. Kind of your subjective, your kind of your judgment. Okay, and then you move to next columns and next column, next column, next columns. So you make after that, you kind of make the judgment, okay, this is patient going to fit 50% or no, or the 40% depends on there's no 45%, 55% like that, just only 50%, 40%. That's how you say that, right? So that is how, you could determine. So that can be used for the not only cancer patients, also for the non-cancer diagnosis as well. So which is at any age, but if you come to pediatric populations, a little bit difficult. We don't really, it's not much use for the pediatric populations, okay? So performance status we use as a communication tool. Like, we talk to among ourselves, okay, what's the patient PPS? Okay, how's he doing? Like PPS 50%, 40%, we know how patients stand, okay, in that particular time. So the 0 time is important. 0 time means when the patient was totally functional, meaning that, totally doing everything like 100%, which is 0 time, right? And then from that time on, you're going to be assessed temporarily, like, how next couple of years, how the performance status change, okay? So, the low score probably, PPS score is pretty low, which is, indicate the short-term survival. And the initial high score doesn't really mean the patient's long survival, but they can change anytime, right? So one of the good indicators is that, rapid deterioration, like patients start from the 70, 80, now go down to 30% within few weeks or few months, which is pretty good, the indicators, right? That patient going to be declining and the patient going to enter that terminal stage, right? So another thing that you need to be caveat is that, you got to find out anything that acutely reversible conditions. For example, sepsis, anemia, uncontrolled pain. So any side effect on therapy, that can temporarily decrease the performance status. That time you probably don't want to say that, oh, patient terminal, right? So unless you treat that, reversible conditions, and then, you treat everything that you can, then, if it doesn't respond, that would be kind of the, you can say that patient terminally enter into the terminal phase, right? So make sure that you kind of identify any acute reversible conditions. Okay, so this is another class, which is the CPS. Okay, so the clinician prediction survivals. This is very subjective. It's vary from physician to physician. Okay, so some patient may say that, oh, patient has 2 months to live. Some physicians say that 6 months to live. So very subjective, and there's many limitations, and it can be reproducible. Okay. So nevertheless, we regard it as a distant class because that correlate, if you look at the, 6 months, 3 months, whatever, then you kind of, they correlate the assessment. Okay, the very subjective. Okay, so so how to assess the CPS? So which is the first one is you can do the temporary approach, mean that how long patient will live, which kind of the subjectively you say that, oh, patient 6 months to live, 2 months to live, 3 months to live, whatever it is, you can say that, right? So another way of saying that is, surprise questions. Okay, so so you ask yourself, would you be surprised if patient die within 6 months? Okay, so so that kind of question you ask yourself. The answer is positive if you're not surprised. Okay, if you say I'm not surprised, then patient is SQ positive. Okay, so that's how you got to determine, and which is kind of it's not that sensitive though. The sensitivity is pretty low. But they have the pretty good negative predictive values, which is the kind of let's say patient. You ask yourself, patients, would you be surprised if patient that die within 6 months? The answer is no, which is would you be surprised, right? Then you can pretty much exclude that the patient may not die, right? So that will be kind of the negative predictive values. Okay, so high negative predictive values, right? Another way of doing that is the probabilistic. I mean, how much probability, which is to do with the kind of more your literature that, well, what the time frame patient, we have the more specific time, look at it, what's the best case scenarios, maybe 2 months. The worst, the best would be like, 6 months or so. Worst case, maybe 2 months. What's the likely scenarios? Okay. So kind of the kind of probabilitist approach that you can also phrase it to, right? So how well we do it, okay? So it's very subjective. So depends on a lot to do with who you are, right? So are you glass half full or are you glass half empty, right? So I'll probably say that if you realistic, that would be better way that you approach it, right? So if you optimistic or pessimistic or the realistic, right? So this is a study of the hospice patients, which is like almost 500 patients, 5 hospice programs, assessed by the 350, physicians, right? The mean survival is 24 days. If you're really good at the making prognosis, okay, so it should be diagonal line, okay? So let's say, you say 1 day, yes, you're gonna be kind of across that diagonal lines, you're gonna be perfectly lined here, okay? So throughout that diagonal line. So every time you prognosticate, you're gonna be, accurate, right? So any dot above this line, which is kind of optimistic, any dot but below this line is pessimistic, right? If you look at here, this is the 6 month predicted survival. You see that 6 month, right? So look at the observed survival. Okay, so the 6 month. So pretty low in that sense, right? So a lot of the physicians, we are very optimistic, right? So look at the 90 days, which is 3 months, right? It's still very, very much, the optimistics. If you look at here 90 days, a lot of the physicians predict that, more than 90 days, right? year 2, right? 30 days, 1 month, okay? 2 weeks. So they say that, 63% are very optimistic and the 17% is pessimistic and only 20% accurate. So based on this data, okay? So this is a forest plot that you probably know. So this kind of the systematic reviews. So a lot of things that, physicians over predict by about 3 times, okay? So that is generally how we do it, okay? So another factors, which are the physical signs and symptoms, right? So which is very important also. Somebody who's losing weight, like, anorexia, weight loss, involuntary weight loss, of course, right? So the dysphagia, xerostomia. See, these are the very telling symptoms. The patients really have the, bad prognosis. So a lot of times the weight loss people know about it, but the dysphagias, yes, xerostomias, a lot of people overlook. Okay, so the patient may say the dry mouth. Okay, so and then that is pretty telling to do with the cancer. Somebody telling you dry mouth, nothing to do with their medications. That probably tell you that poor prognosis. Okay, another one is dyspnea, tachypneas. This is also the persistent. Okay, the more than 24 per minute for a long time, which is not good. Okay, deliriums are very poor prognosis too, prognostic indicators, right? Another one is sustained tachycardias. So these are the kind of the indicator that you got to look for. And the other one is psychology factors, which is kind of the very controversial. Sometimes patients say, I'm a fighter, I want to fight to the end, whatever it is. This is kind of the very controversial, kind of really tell one way or another. So another factors are kind of look at the biologic factors, which is, leukocytosis, lymphopenias, etc., and the low albumin, and also the tumor characteristics, either primary, secondary tumor sites, complications. These are the kind of, sometimes you got to tell the patient that one complication can happen, right? Embolism, bleeding, infection, that can be causing you that sudden, demise. Okay, so the other one is the comorbidity. So somebody with a cancer to do with the, along with the heart failures or COPDs, liver failures, kidney failures. These are the poor prognosis. So let's move on to the non-cancer prognosis. Any questions so far? I'm sure I'm going too fast or not. I don't know. If not, I'm going to move on to the non-cancer prognosis. Everything's okay, right, Dr. Eiji?
Yes ဆရာတို့အခုချိန်ထိမိကွန်းများမေးစရာရှိလားရှင်မရှိရင်တော့ဆရာကနောက်တစ်ပိုင်းကိုဆက်သွားပါမယ်ရှင် Yes everything's okay
Okay, great. So let's talk about the non-cancer prognosis. Okay, so so CHF, which is kind of the very common, CHF is very common in the clinical practice. So there's a 3 classification you may know that, right? One is the staging, so which is stage A, B, C, D, like a cancer diagnosis, right? So the stage A, B, C, D, So and the another one is functional class, NYHA class, which has been used for a long, long time, even earlier than the heart failure staging, right? So the like 90, 80 somewhere around. Okay, so the another scale that we use is intermesh scales, which is kind of the for somebody with the advanced, the heart failures, right? If you look at here, the stage A, B, C, D, when you a lot of patients that we see in the clinical practice are stage C. So they kind of come to hospital, exacerbation, and then they discharge again, they get the treatment, they come back again, this kind of the stage C, right? So that could be, patient can present with the kind of the functional class would be kind of depends on the where patient, the exacerbation is, right? So when they present to the hospital, they might be class 3 or 4, they might be very dyspneic, they cannot do a lot of activities, but when get treated, they went back down to the class 1. Okay, so then, come back again, the same thing, right? So stage C is kind of, you can see that all the classes in the stage C. And the stage D is kind of the more refractory heart failures, which is kind of really, we call it end-stage heart failures, right? So the So endemic scale is kind of that some overlap between the NYHA class and endemic scales, right? So if you look at here, the first class 3, which is the endemic 7. So the 3Bs, which is 7, 6, and 5, and the class 4 is kind of the dyspnea at risk, right? That's class 4, the kind of the NYHA class. The 4, 3, 2, 1, which is kind of look at here. The frequent flyers mean they admit to the hospital many times. So the class 7 is kind of the advanced heart failures. Then walking wounded, they're kind of very limited functional capacities. Housebound, which is totally in the you cannot go anywhere, right? And if you walk a little bit, to the back and forth to the bathrooms, you get short of breath, right? So frequent flyer, which is kind of the patient admitted to hospital many times. You might see that, in your practice, patient admitted again and again within 6 months or so. A lot of patients going to ICU, CCU kind of thing, right? So class 3 is kind of dependent on inotropes, which is needed to be, mirinones or the dobutamine drips, that's depend on that. And the class 2 is, which is kind of the sliding on inotrope. Patients continue to decline on that inotropic agents. And class 1 incursion, but many patients kind of really dying process. Okay, so if you look at the NYHA class, that is kind of old data, but still relevant. Even with the all the treatment advances. So they have a 1-year mortality. Pretty, if you go to class 4, which is pretty bad already. Like 1 out of 2 patients may die in the 1 year. Okay, so this pretty almost the people compare with the cancer prognosis actually. So this is another way of saying that the 1-year survivals. So based on the functional class and the endemic scales, like 5 to 7 months to year. So this is a ventricular assist device. Okay, so the established and the 3, 4, which is weeks to months, 1 to 2 hours to weeks, and the multi-organ failures, right? So the which is kind of the you got to determine whether you're gonna let them die or the other treatment like organ transplant, anything like that, right? So that's how you're gonna look at the severity. Okay. So heart failure prognosis, very high mortality, as mentioned earlier. So the man's a little bit higher mortality than the woman. Over 65, 70-80% will die in 8 years, and the time interval between solution lesson means that every admission, every exacerbations, nothing to do with the medication. Sometimes patient miss the medication, exacerbations are different, right? So even with the guideline, directed medical treatment, patients still exacerbate. So each exacerbation, interval between that is kind of when you get disease, advances, you get the list, closer and closer each exacerbations, right? So because of the nature of prognostication with the heart failure, it's kind of hard to making prognosis, which one will be the patient going to die and which exacerbations. Very hard to tell, right? So another thing that, caveat is that, high incidence of the sudden death. Okay, if you look at 20-50%, you can get the arrhythmias and patient may die, suddenly, right? So you got to warn about the patient as well, right? So another thing that you need to know is, normal EF and low EF. Somebody with the preserved heart failures or the reduced EF or the normal EF, there's similar prognosis. There's no difference at all. So heart failure prognosis variables, which is the kind of the variable that you look at, more severe heart failures, the NYHA classifications, recent hospitalization due to the heart failures, decreased EF, systolic blood pressure, heart rate, okay, cachexia, cardiac cachexias, right? So your patient lose weight due to the heart failures, right? So poor prognosis, reduced functional capacity, mean the patient cannot do that much at home, while that's pretty bad prognosis, right? So you probably know the anemia, hyponatremia, increased BUN, renal, cardiorenal syndromes, poor prognosis. Other comorbid conditions like COPD, CVAs, diabetes, that poor prognosis as well, right? So move on to the COPD, which is, you said the scale called the BOD index. Okay, so the BOD mean like body mass index, the airflow obstructions, dyspnea, exercise. Okay, so what you do is, you could look at the, the FEV1, so 0, 1, 2, 3, right? So the you fit the patient here, where you're gonna fit, and then you move to here, 6 minute distance, right? So the this is based on the meter, right? So how many meter patient can walk in 6 minutes. So then you got to get another number here, and the dyspnea scales. They usually modify medical research, which is the kind of British, the research scales, and the BMI, right? And then you put together here, and all the number you combine here, and you put it together, and then you can see that what the prognosis will be. Like you can put it in, right? It BOD index is pretty high. It's 52 months, which is about 2+ years, right? So that the 1 year 5%, 2 years to 31%, 52 months, which is like 80%, right? So this is mortality, right, for COPD patients, right? So end-stage liver disease, same thing. You see that MELD scales, that's what we use. Also come with the survivals, depends on what number is that, you get the British survivals, right? So the 2 years, right? So the 33% if you get high number. Okay, so the end-stage renal disease, which is also there's some range also, depending on the performance status. Okay, so the this number of days the patient may die, right? So somebody initial site of care is a home, hospital, inpatient hospice. This number of days, the race, male, females, oxygen use, peripheral edema, non-peripheral edema. So the some of the patients are kind of they have the high output renal failure. Sometimes patients are making urine, right? So they have no edema. They can survive a little bit longer. I've seen recently one patient also, 100 years old, he died like, pretty long trajectories. So generally when patients have stop the dialysis or the end-stage renal disease without dialysis would be like 7 days, 7.4 days, mean survivals, right? It could be 0 to 40 days, right? So stroke is another diagnosis. If you look at all the variables, if you have a coma, loss of brain reflexes, midline shift in the scan, NIH as a score, severity is very high, severe, advanced age, the comorbidities, again, the pre-stroke disability, which is the functional status prior to the stroke, right? And stroke-related complications, hemiplegias, urinary incontinence, case person, dysplasias, right? The type of stroke, yeah, of course, hemorrhagic was an ischemic stroke, and the pre-stroke, the impairment, cognitive impairment, were very important. Somebody had the dementia prior to the stroke, they have a very poor prognosis. Low Jesus score, need for mechanism ventilation, basal artery, Congo is very good, very poor prognosis too. The size and volume location. These are the kind of somebody come with a kind of very large infarct, right? So they have a very poor prognosis. So to do with the advanced Alzheimer's dementia, right? So if you look at here, the progressive loss of ADLs, if you have the early, the dementia, they can still keep some of the appointments, the use of the telephone. So this to do with the IADLs here, the instrumental daily living. So then if you move to the moderate dementia, which is like, you can lose, when they travel somewhere else, they lost in neighborhood, they're gonna go able to come back home kind of thing, right? So this is not safe to use the fires, cooking and this and that, they're gonna find the belongings, lost the keys, that kind of stuff, right? So that's a moderate dementia. And if you get to severe dementia, which is like 10 years or so, right? That's kind of the time frame is very, variable, usually come with the decades, right? If you go to mini mentals, the very low mini mental, which is you can't even communicate anymore, right? Now that people use a mocha, right? So unable to eat any by themselves, that would be kind of a prognostic functions, right? So For the hospice eligibility, we use the functional assessment scales, first scales. Okay, so the 1 to 7. Okay, so if you look at from the top to bottom, which is kind of the scale that is more than 7 is kind of the people say that more accurately more than 7C, which is kind of the you can be hospice eligible in that stage, right? If you go from the bottom to top, you can see that this is kind of the child development. Okay, so that's how they kind of reverse the child development in the sense of when they go back to the Alzheimer's dementia, right? So if you look at your lost ability to hold, okay, this is what the baby does, right? Smiles, cannot sit up, patient, the kid can sit up here without assessment, and the ambulatory, started walking. So when you get to that cannot walk, cannot talk, that's the time the patient in dementia patients is kind of the eligible for the hospice care, right? So there's some other skill that you can use, advanced dementia, but I'm not going over that one, okay? So now that we talk about the prognostic, the foreseen, right? So now we're going to talk about the estimating prognosis, which is kind of you gather all the data that you can accumulate it. Look at the patient chart, patients, ask the family, and then you ask all the informations, and you're kind of projecting yourself to with the time frame, right? So of course you got to look at the general indicators, performance status, nutritional status, emotional states, right? Disease-specific indicators, diagnosis, cancer or non-cancer diagnosis, stages of disease, also the natural histories, or the clinical course with the treatment, right? Trajectories, general individuals, the rate of progressions, very important too, because they have a different rate in the different patients, right? Comorbid conditions, and the Hospice, the new complications, can arise or not, okay? So in the hospice, what they use the kind of NHPCO, which is kind of the National Hospice Association, that they have a terminal state. There's some description about the who will be hospice eligible, right? So that you can use that too. You can look at it, right? So some of the numbers are very important as well. If you get to that malignant hypercalcemia, pretty bad prognosis, pericardial effusions due to the cancer, carcinomatous meningitis, very poor prognosis as well. Brain mets, without radiations, 3 months to 2 months kind of thing, right? 6 months. So malignant ascites, poor prognosis. Malignant perfusions, poor prognosis, right? So the malignant bowel obstructions, which is kind of the less than 6 months as well. So there's a number that you can rely on as well, which is we can get it from the first fact. I can show you I added on that website for that. That you can look at that one later on. Okay, so there's a lot of the informations in the website first facts. So this is the 1 year. Okay, so there are different diagnoses, right? So the cancer, non-cancer diagnosis, right? So so this is the 6 month, 180 days. And then if you look at here, so a lot of the cancer diagnosis have some kind of predictability, right? So this is the box and whisker graph, which is the kind of the range, 75%. This is the outlier, right? So all the whiskers are outlier, right? So the middle numbers are Maine's number, right? This is the main score here, right? So if you look at here, the non-cancer diagnosis, they have a pretty wide variability about the prognosis. They survive a little bit longer. Dementia, if you look at here, like some patient may last for at least 3-4 years, right? So the COPD is pretty wide also, right? CHF is pretty predictable. Stroke, yes, but the cancer prognosis pretty much, within the range. Okay, so this is the trajectory that we normally look into that. So before we do the predictions, right? So the first graph is the rapid decline in performance status, which is we're talking about the hours to days kind of thing, right? So somebody with the accident, of course, you're gonna die right away, right? So major accident, right? Sometimes patient may have the large stroke, massive, heart failures, massive, the heart attack, so dissections, this kind of hours to days, right? And this one is the graph B is kind of that more to do with the cancer prognosis, cancer trajectory, right? So in the beginning, they're okay, they get the treatment, they will decline performance status. When you get to terminal stage, like 2-3 months, then you get the rapid decline, which is irreversible decline, right? So usually about the terminal stage, okay? So the trajectory C is the kind of the organ failures, which include heart failures, COPD exacerbations, right? Yeah, end-stage liver disease, end-stage renal disease. What happened? They kind of the exacerbations, patient decline, they get better a little bit, go back to baseline or not. They come back again, like one of the peak and valleys, one of the value patient may die, right? So this is kind of the typical organ failures, right? So the trajectory C is D is the one that somebody with the poor performance status from the beginning, which is Alzheimer's dementia, ALS, that kind of spinal cord injuries, that kind of patient go to that trajectories, right? So they kind of the very poor performance status begin with, and you get all the complication like the aspiration pneumonia or the pressure ulcer kind of thing, right? UTI, you can die from that. Okay, so the complication from the chronic illness. So this is how you're going to look at the whole pictures, right? So the factor influencing individual prognosis. So always look from that's the objective finding, right? Or the pathology, like cancer or non-cancer diagnosis, and then you get the diagnosis and the treatment, okay? That will determine the prognosis, the clinical findings, general prognosis, and then you're going to predict to the individualized prognosis, okay? So which include the psychological factors and the comorbidities, right? So that's how you're going to kind of put yourself in that, the sense, you kind of formulate yourself, what patient may have the prognosis in next 6 months, a year, whatever it is, right? So that is to do with the estimating prognosis, right? Now we're going to move on to how to communicate the prognosis to the patient and the family, right? So as I told you earlier, because we're kind of very optimistic, generally, right? So we always say that, oh, we kind of minimize, sugarcoat the what we want to say. That is not really, the good strategy, right? So if you look at this, the study that's been like, since 2001, but if you look at here, the middle graph, this is a Kaplan-Meier graph, right? So which is the middle one is you estimate, you formulate it, meaning that, you think the patient may live, say, 75 days, right? But when you communicate to the patient, the family, you say that, well, 90 days, right? So then patient actually survival is kind of the 26 days. Okay, so that is how we communicate to the prognosis to the patient, the family. So what happened, they're kind of surprised. I mean, look at here, 1 month to 3 months, right? So 3 times somewhere around. That's how we communicate. It's probably not a good idea, right? So always there's an optimism, okay, some benefit if you, say sugarcoat it, you'll be fine, patient may be okay, they be compliant with your treatment. And also use it in high-stake patient. Yeah, I mean that, some patients are very demanding and this and that. You probably, don't want to confront them. Okay, so that's why you're going to say, oh yeah, you'll be fine. You tap the shoulders and then there you let it go, right? So sometimes you'll be okay, helpful in the shade of the positive. If you say positive, people happy, right? So you're okay, right? So you don't have to handle the emotional issue. Okay, so that, that will relieve your burden, right? So the risk is that they give the false hope to the patient and the family, right? So they don't really prepare it. That can be these patients may treat until the last minute they get the chemotherapy hanging, right? You probably don't want the suffering, so you probably stop where the patient need to be stopped, right? So you got to have the late referral to hospice benefit. There's no end, no preparations. This is a risk of the optimistic, communications. When you're pessimistic, there's another risk also, right? Risk and benefit, right? The risk means that, well, patients, you say that, well, patient going to be less than this long, if you protect you against the unexpected outcome, right? Patient die, I told you so, right? So that's how you're going to say, oh, yeah, I told you that, you're going to die, right? So that is not really good also. You have the time to give the preparation of the patient, the family, right? So they can prepare, their financials or any asset, so no lose strategy. If outcome is okay, you're covered. Outcome's poor, you cover it. Outcome's good, you're a hero, right? So the lawsuit, I don't think it's not much in the your where you practice. They avoid giving a false hope. That is another even though you're not giving false hope, but you have the kind of the some of the treatment that might beneficial to the for the patient, you might forego that. Mean that you may not get that treatment. So just as I'm always at the balance, right? So I can probably share one of my experience on the one of the patient that I was training. Patient was discharged, come to our unit with the hospice, the diagnosis breast cancer, right? So what happened? Hospice mean that patient may be dying from other hospital. They come to our unit, and then what happened was after we treat the pain, because his performance has decreased because of the pain, right? So what happened after we treat the pain, patient really get better. So she even went through the additional 2-3 years chemotherapy and the for the breast cancer. The problem is that she gave her house to her daughter. So when we're about to discharge, she has no place to go. That was a problem, if you think about that, this is kind of the risk that you're going to be seeing, right? If you say that pessimistic, patient might forego the treatment, then, if you already arranged do that, that financials, estate and this and that, you may be having problems. Okay, so so another thing that the staff attitude, meaning the patient already hospice, patient come to the emergency room. Well, sometimes patients say, oh, already hospice patient, what are you going to do with this, right? So patient already DNI, I don't want to, they have a different attitude to do with that the stigma, okay, hospice or the DNR stigma, right? So you got to be careful with that. Either way, you don't want to be too pessimistic as well as too optimistic, right? So disclosing the poor prognosis is very important, right? So this is your duty. I think you have to tell the patients, or the family that what is coming, right? More ethical duties. This is your clinical responsibility as well, right? So also you can use a communication protocol. I think you may be taught or not. It's another totally different lectures, right? The spike protocols, remap. As you may heard about this, remap is kind of the reframe, expect emotions, map the future, and the what the let me see what the so remap that protocol that you can use. And you also manage expectations, right? Expectation mean like what the can be what can be happening in the future, and the either good or bad, right? So you also admit the error. Okay, so something a lot of times the prognostication is very fluid and the difficult to predict. So you may make some error. I did all the error all the time, usually, your error is kind of your prognosis lasts only weeks to months, right? So that you don't really, if it's changes, you're going to make the changes, change your prognosis also, right? So what are the techniques? You got to do the homework. Mean that, you got to look at your, all the number, data, assessment, look at the patient histories, do the whole homework, okay? And then, when you talk to the patient family, they need to really wants to know. You got to find out, okay, you got to ask the patient that, well, Are you really wants to know the truth, or are you to get the clear invitation? Yes, I really want to know how much time I have left. So then you're going to be disclosing, right? Otherwise, you probably don't want to say, oh yeah, you come in the round and you go, oh yeah, you're going to be dying. You don't say that like that, okay? So you got to have the clear invitations from the patient and the family, right? So culturally sensitive means that, sometimes, in our culture, we always talk behind the patients, right? So it depends, it's up to you guys, but I usually ask the patient whether they consent to talk to the patient, the family. The patient's consent, well, you can talk to my son or my daughter, then you can probably talk to them, right? Otherwise, you probably have to, respect their autonomy. So I always go to the patients and tell them what can happen or your prognosis. And be humble and find humility. Mean that, you're going to acknowledge your uncertainty, whatever you say that inaccurate sometime, right? So sometimes you got to talk about the unexpected events like arrhythmias, maybe bleeding, maybe, the infections or, sepsis. So that can really, give you the unexpected, situations like bleeding, right? I have one patient the kind of the carotid blowout, he died right there, within like 3 minutes or so, right? That can happen also, right? So prediction may change from time to time, so which is dynamic. I might say that, on admission, patient may have, certain amount to live. After treatment, we treat, symptoms and this and that. Patient survive a little bit longer. That's okay. You can say that you've changed your predictions, right? That's okay. So you got to tell them, right? So when you disclose the trajectory, you always give the range, not the number. You have only 1 month to live, 2 months to live. No, you don't say that. You always give like, hours to days, days to weeks, weeks to months, months to year. So that's a kind of range that you're going to give it, right? So not the absolute number, right? So you also write the phrase of, oh, only God knows, you don't want to, it's up to us, not up to us. You probably don't, say that kind of stuff, right? So you got to be kind of give some ideas how much time patient may have, right? So that is to do with the prognostication about the terminal state, right? Any questions now?
Let's say checkbox ထဲမှာပို့ထားလေးရှိ 68-year-old man, long history of COPD, frequent hospitalization for exacerbation, now oxygen dependent gehasia, severe breathlessness, arrest. Recently his issue dyspnea, anxiety, polypharmacy, family pushing for ICU admission, but he does not want to go to the hospital. How can I manage this patient?
This is a years old man, long as COPD. Yeah, number one, Dr. Tim Yowen, I think very poor prognosis, this patient, if you look at the board criteria, is pretty bad actually, okay? So the number two is the issue of dyspnea, anxiety, pharmacy, yes, family pushing for ICU admissions, but he does not want to go to hospital. How can I manage? So, well, you got to really, respect the patient, the wishes. I think patient want to die at home. Probably that is what happened. I think probably, you have to really get the family meeting with that patient family. I think, this patient that you described is poor prognosis, right? So I think we should respect the patient's wishes. But you can manage with the dyspnea, you can manage with the opioids, which is morphine or the dilaudid, whatever you want to do, you can do that, right? So that will help with the a lot of a lot of time the patients they're kind of they don't want to see patients suffer. Meaning that the patient short of breath, patient rush to the hospital, right? So you can manage with opioids, other dyspnea management, you can do that. And yeah, we'll probably get the family meeting probably. Okay. The another one is some 2 years old female prolonged bed rest, severe anemia, stool, positive. Maybe there's a small gallstone. Okay. Well, the number 2 patient, with the chronic RA, I don't know what the performance status is, for that particular patient. If you have a poor performance status, probably, you probably, give the comfort care goals. I'm not sure the patient terminally ill yet, in that stage. Chest infection, that would be kind of the bad one, because chest infection, steroid-induced diabetes mellitus. These are the bad problems. Vitamin D is another one. So, that patient in declining course, I think is going to get to the terminal very soon, I think, probably. So about the RA treatment, that you got to talk to talk with the rheumatologist also, like, whether, I don't think it will impact that much whether you treat or not treat. That is my opinion. Okay. All right. Let's move on to the next topics. Let me see. Let's say patient, they become terminally ill, you transition to the hospice care. Okay, so so when you transition hospice care, that's in the United States, we have the hospice agency. They work independently from the hospital or the other health system. They have their different rules and different regulations. So there's a lot of agency in the hospice in the United States, and what they do is, listen, the Congress, say that you have to provide that the hospice level of care. Patient become hospice appropriate. Patient agree for the comfort care goals. Patient agree for hospice care. You become hospice eligible, right? So when you enroll into hospice care, hospice agency will take over the overall patient care, right? So they determine that what level of care the patient may need. Okay, so the number 1 is routine home hospice, which is kind of the very low level, meaning the patient, the family have to take care of the patients themselves, right? So hospice nurse will visit the patient and the family like maybe once a week, twice a week, something like that, check the vital, give the medications, something like that, and then they kind of monitor you, right? If patient become more symptomatic, they can do 2 things. One is, they can provide a lot of symptom management at home, and they can increase your hours of the care at home. The nurse will be a little more longer, stay with them, like, more than 50% of the time, like, the nurse will be there continuous. Okay, so they mean that someone would be with the patient from the hospice team will be with the patient to manage the symptoms and the time process, something like that, right? So if sometimes patient may need inpatient level of care, which is kind of let's say patient need the pain medication intravenously, like, PCAs or the dilated PCA, fentanyl PCA, that kind of situations, patient very delirious, you can admit to the hospice unit. Okay, so that's inpatient hospice care. So sometimes the hospice will provide the respite care, which is kind of the caregiver burden to the patient families are kind of tired of the caring for the patient. It's kind of day in, day out. You can imagine it's a very tolling to the caregiver, right? So they can give the break to the caregiver. They take the patient to the hospice, unit, and the hospice care, the family can go somewhere else, right? So they can take some break. So the number 1 thing that you have to know that, patient, you're going to recognize dying process taken. This is, I'm talking on the prognosis, right? The patient is starting to die in early stage. You got to really understand that, recognize that, dying process taking place. So at that time, you got to prepare the patient and family. We call it coaching, right? So we don't say the education, we just call it coaching. You kind of the coaching means that you kind of take the family along the the care process, right? So another one is how to manage the dying process, when the death occur, and the how to manage and the bereavement care, right? So these are the kind of the stages of dying, right? So when patient become transitioning from the the terminal stage to the dying process, so patient may be, spend most of the time in the bed or the in the in the chair, right? So they may have the reduced appetite, increased fatigue. They may be more and more bed bound, and they spend time more in the sleeping. Okay, so they withdrawn. Okay, these are the things that you're going to see when patient in transitioning, right? When they become actively dying. So that's the time that you see the about hours to days, which is patient symptom getting intensified, and they get the irregular breathing, loss of consciousness, they comatose, extreme getting coughs, decrease in output, skin changes, kind of skin modeling, like the levator reticularis kind of thing. You're gonna see that, and paler, right? So 5 hours, breathing becomes shallow, labor breathing, weeks, pulses are very weak, irregular, and the person become more and more unresponsive. And the eye either open or partially open, and then you're going to see some kind of twitching, choking that can happen, which is to do with the metabolic, affecting the brain, right? So when the occur, you can diagnose it, right? Because that one, I want to go through that one for now. So this is kind of pretty old, but it's kind of the way that you can look at it. Number one is dead rattles, which is kind of the patients usually they lose the capacity to swallow, right? When patient, become actively dying, right? So what happened? All the secretion that they produce in the anomaly, they cannot able to swallow anymore. So they kind of pull up in the throat, and when patient breathe in and out, you're gonna have the rattling sound, which is called dead rattle. When you hear that, about 2 days, right? So the 24, 48 hours, 3 days, somewhere around, right? So another one is respiration with the mandibular movement, which is another thing that, people call it the agonal breathing. When you breathe in, the jaw drop, which is the kind of the breathing with the respiration with the mandibular movement, right? When you see that features, clinical signs, patients are very limited time, like hours, like 8 hours, somewhere around, right? Cyanosis, 5 hours, like a radial pulse, 2 to 3 hours. Okay, so that is how you look at it. So this is a little bit more recent literatures, right? So if you see here, the dysphagia liquid, decreased level of consciousness, performance status less than 20%, pretty see the right. So the very 20% is really totally bed bound, right? Peripheral cyanosis, change stroke breathing. Sometimes you see that change stroke, the breathing in rapid becomes slower, kind of thing, right? The urine output is very specific. So if you have the less than 12 hours, less than 100 cc, pretty good range, like so 1 to 2 days, right? Okay, this is kind of the apnea episode, respiration, the mandibular movement, dead rattles, the pulse lessons of the radial pulse. These are the kind of very specific findings that you're going to see. Urine output is pretty good indicators. So when you have this is 7 days, 7 days mean like, the before death, right? Minus 7 days. Your symptoms is less, when you get closer to dying process, you get the more symptoms as well as intensity increase, right? Number of symptoms increase as well as intensity increase with that when you get that dying process taking place. So other changes, which is the fever, somebody you get the fever, you can get it, sweating, diaphoresis, seizure can happen, defibrillator shock. So somebody with the ICD, you can get shock. Okay, so if you're not, deactivated, right? So another one is pre-death surge. That can fool the patient, fool us, quite often. Right? They call it golden glow. Sometimes, patient kind of really unconscious, and then all of a sudden they woke up, right? So and then started eating this and that, everybody happy, and then well, I don't know what happened. Then next 1 or 2 days, patient decline again. So that kind of the surge or the burst that you have, energy burst. So sometimes coincide with the whatever the visit, family members, whatever that can happen too, right? It's called the golden glow or the the energy surge that you can have. Especially pneumonia, especially the asphyxiations and the hemorrhage, hemophysis, exsanguination. So these are the kind of the bleeding complication you can get it to. Usually you got to really get the duck towels, at the bedside if patients are risk, like somebody with liver failures with the esophageal, that hemorrhage kind of thing. You can get kind of, you got to be careful with that, you know. A lot of people, if you with the, you know, the white towels, you know, all the blood, you know, you can see that, you know, right away. It's not really a pleasant scene. So you got to really get the dark towels so that you can kind of, you know, minimize the shock. Okay. So you're going to prepare the patient, the family. If you see the changes, you're going to let the patient, the family knows, not the patient, family knows, and the team approach, teach what expect to the family. Facilitate the life closure. You know, you got to tell them, you know, what to do, what to say, what to do in the life closure. In our practice, usually you have the kind of the rituals and rites. You know, usually you get the you know, get the Dhamma talk of the family member. You know, or the or you know, the monks come in, get the rituals kind of thing, right? So with the funeral arrangement as well, financial legal matter. It's a bit too late already. So you start this, you know, financial matter a little bit earlier than that, right? So provide the ongoing support. So the coaching I tell you earlier, right? So the coaching is kind of sharing the knowledge, working with the family as they go through the dying process. So so you got to really let them know what's happening along with the changes of the dying process. So in order, when you do that kind of coaching, you know, that will reduce anxiety and fears, you know, you can give the confidence to the family so they can take care of themselves instead of you taking care of them, right? So you teach them how to do the mouth care, you know, how to turn the patient side to side, this kind of thing, right? How to do you can get the empower the family, right? And they can value that because, you know, they want to care for their loved one. So that, you know, they will be helpful for them too, right? So that will also, you know, good memory for them. Okay, so preparing the impending loss, which is kind of the grieving. We call it the anticipatory grief. You know, when you have the, you know, impending loss, you got to start grieving before the patient death, right? So you have to be the shifting the roles and responsibilities. You kind of you can, you know, rely on the family members to care for them. So that will be helpful for us too, right? So there's a lot of question along with the, you know, the dying process occur, you know, how much time left, you know, even though patient may be dying process, they still want to know. You know, I've seen a lot of, you know, things that they ask all the time, you know, even though you see the patient may die in process, they still want to know when it's going to die, right? They don't want the patient to die alone, right? So is he suffering or not? Is he in pain? You can say that, you know, if your patient's in you can observe the patient that, you know, the pain behaviors. You can tell them, you know, is in pain or not. Suffering is very hard to tell sometimes, right? So very hard to tell is suffering or not. So why stop eating? Because of the, you know, natural process, right? So they stop urinating. Why patients so drowsy? This is kind of comatose, so you got to explain to them. So they don't talk to them. So what's the reason for that? You got to answer to them. Okay, so so does he know that will be another thing, the tricky thing. You know, sometimes, you know, I'm going to come to the next slide, you know, that will tell you how to communicate. Shall I talk to him or not? Okay. So this is a sequence of losses, right? So the patient doesn't hungry anymore. And then the next time is, you know, they don't thirst and they don't have any sense of thirst. They lost speech. They lost the visions, the hearing, the touch. The touch is the last to lose. That's all, you know, say that nobody knows, you know, this kind of the traditional teaching that we've been doing. So when you answer the question, well, you know, when you come to the bedside, they might hear you. And, you know, if you touch them, they might know that you're here, right? So that's how you're going to say. Patient may not see anymore that time. They lost their vision at that time already. So another thing that, you know, you ask for forgiveness. This is kind of which is kind of that he's a kind of the earlier, you know, the guru from the hospice, the palliative care. You ask for forgiveness, you forgive, and you say thank you, I love you, and they say goodbye, right? These are kind of the tasks that you do, right? You got to educate them. But in our culture is a bit different. You probably know. You want the patients the last minute. So disabled, right? So they say, you got to be very clear from the attachment. I think that would be our value, if in the Buddhism perspective, right? So you want to be kind of more towards the Dhamma and this and that, right? So this depends on how you approach. So how you manage time process, the two road to that, so this is a two road. A lot of times the usual road, which is kind of the patient become more lethargic and optandric and semi-comatose patient die, right? Sometimes patient have the very uncomfortable, the process. They're very delirious, the hallucinations, they be, pulling the hands, the very uncomfortable for the somebody watching them, right? So you got to be understand that that can happen too. So you have to manage that. Okay, usually you can patient die very peacefully, but the difficult road very difficult, right? So what you have to do, you got to manage the peaceful environment, notify the host family and planning that. The 5 Ps are very important also. I learned from the one of the nurse, when I started education. So it's kind of the troubleshooting with the agitation. Somebody patient present, in the dying process, they agitated. So first of all, you got to troubleshoot whether they have the pain, whether they have the urinary retentions. Sometimes they have the fecal infections that can be uncomfortable. Patient can present as the agitations, right? They cannot tell you that they're happening, right? So you got to really preempt it, get the catheter in, get the infection relief, pain relief, right? Polypharmacy, another one also. If you have a lot of polypharmacy, a lot of medication that can be interacting, especially in the end life, they have a renal organ system shut down. So you can be agitated to cut down all the medication that not needed. And other one is a pulse oximetry, like low saturation that can cause you that, agitation as well. So you got to troubleshoot the before you manage medically, right? So you're going to switch the route of the pain medication, like, you cannot swallow anymore. So instead of you get some pain medication, use IV or subcute, right? So you can do that. So medication, the life-sustaining treatment, you have to really, remove it. Some medication doesn't need it. Stop monitoring vital signs. So you're going to manage other symptoms, right? So pain is another one that whether increase, decrease opioid. That's another thing that, sometimes, you have to really determine what is, either pain related agitation or the nothing to do with the pain, right? So pain, the pain can present you as a deliriums. So you can get agitations, you can misinterpret it as a pain. So what happens, you tend to increase the pain medication. So when you have the increased pain medication, because the end of life, you have the organ system shut down, like renal failures, that can accumulate the morphine metabolites that can agitate the hyper the brains and the neurotoxicities. So you can get the hyperagisia. You interpret as a pain also. So what happens? You tend to increase the opioids. That is not good. So you can present as a myoclonus, or then you can get the seizure attack. So you got to really look at it, the whole picture, whether it's to do with the opioids or not. Okay, so if you have the opioid related agitation, you got to decrease the opioids as well, right? Another one is the respiratory secretion, which I'm talking about the dead rattles. Okay, so the at home setting, you can do the eye drops, atropine eye drops. Copolamine, you can use the patch, but it's we don't use that much. So you can use the glycopyrrolate, which is the quaternary ammonia. So that's kind of the very big the molecule doesn't cross the blood-brain barrier, so you don't have the usually uses the anesthesiologist use a lot. So what they do is use the subcutaneous injection, so they're going to give you the anticholinergic effect without the crossing blood-brain barriers. So that will not get the confusions get worse. Okay. So obstruction of dyspnea, you can use the opioid, which is very good. Ativan, benzodiazepine is also important. and also the oxygen, supplemental oxygens. So another thing that you can use a fan, to the bedside. So the saying that the fans that can stimulate the fifth cranial nerve, so that can relieve the dyspnea. That's all the saying this, right? So you can say chlorpromazine also, right? So let's move on 5Ps. If you become terminally delirious, then you can, of course, you're going to say, look at the rule out all the other causing the deliriums. If not, you can use it Haldol, either sub-Q or IV IM. You can do that, the low dose IM, and Ativan or the benzodiazepine, these Versed, or say Thorazine, which is kind of very old psychotic, the sedative powers, right? So you can do that, right? Seizure, use the benzodiazepine, of course, rectal, phenylphenidone and phosphonidone, phenobarb, which is kind of you can use it also for seizure, right? So pacemaker, so time is up probably. Pacemaker, you don't have to do that much, okay? Pacemaker is kind of in the past they said, discontinue pacemaker is no longer the practice anymore. ICD is important. ICD, you got to really, patient dying process, you very uncomfortable. Patient shocking, right? So usually patient die from the ventricular, the asystole or the deeper, fibrillation. So that you probably have to really stop that. So if you're not available in the we use here you see the magnet, you can put the magnet on top of the ICDs, right? So you tape it. So that will stop the sensing of in the home setting. If you have no time, if you have time, you call the company, they can come and deactivate it. So hydration, nutrition, you got to be advised not to do it because that can choke in the patients, right? Antibiotics, sometimes it's beneficial. Hemorrhage, dominant sedations, right? So you try to do everything you can, but patients still refractory to what you're doing. So you can do the palliative sedations, right? Which is different from the euthanasia and the physician-assisted suicide. So the euthanasia is kind of the legal in the European country. Probably Netherlands are number one that they started legalize the euthanasia, which is involved with the physician themselves. They induce the death with a lethal dose of the medications to the patient to end the life. Okay, that is the euthanasia, which is different from the physician-assisted, medical aid and dying. That's how they call it nowadays. PAS, which is kind of the legal in some of the states in the United States, which is the physician prescribe the medications, lethal dose of the medications of usually barbiturate. So the patient will be put in the bedside. What they do, when they, ready, they take the medication themselves, not by the family member, not by the physicians. They have to take themselves to end the life. Okay, that is the PAS. Okay, so this is kind of the PAS. So palliative sedation is very different from the other two categories, right? Which is the kind of the legally accepted in all United States, all states in the United States, and they also supported by the major medical organization, which is ACP, AMA, AHPM. So they support it. When become refractory symptoms, you can do the control the symptom with the medications, which is the therapeutic dose. Okay, so not the lethal dose. Therapeutic dose to the proportionate to the symptom relief, not to the overdosing or underdosing, just the right dose to the, the goal is sedations, not to death. Okay, that's very different from the previous two intent. When you do that, you do really process, very close to dying process. Mean that hours to days. That's the time that you can do that, in that PST. Okay, so not the like few days, weeks before. No, you don't do that in the earlier stages. Only in the really end of life. That's approximately the dying process. Okay. So the way that they phrase it, this the principle of the effect, which is kind of the that's the principle of the for the PAS, not the PAS, I'm sorry, the PSG, right? So the action must be morally good or indifferent. Mean that actions, what you do, the medication, pain medication, or the that you give it has to be have the morally good and indifferent in terms of outcome, right? So when you act with the good intent, mean that intent is not to patient dead, just to relieve the symptoms. Okay, that is another intent. Okay, so the good effects doesn't have to go through the bad effect. Mean that in order to relieve the symptom, patients has to suffer the additional consequences, but the harmful effect has to be kind of the side effects, not the primary effects. Okay. Another principle is the proportionality, which is we give the medication or the any intervention that will be kind of proportional to the suffering, not to the dying to patient death. So that's how they based on that, the Christians double effects. Okay, so that may be different from our belief, but that is how they phrase it, right? So this is kind of the cartoon that I have, I just want to give the patient to be a quiet environment. So sometimes, a lot of visitors, they come and do for the, I don't know, they come for the, to get the debt or something, whatever. So they don't be too inquisitive, right? So they just let the patient, I seen that sometimes, they post it like in the social media, the patient die. I don't know. I don't feel like that's the right thing to do, but it's probably not really a good idea. When that occurs, I don't have to go through. You guys know how to diagnose that, right? So when you do die, when patient die, you gotta pronounce the death. Of course, respect it. Depends on the culture, right? Depends on your religions, right? So you gotta provide sufficient time. Sometimes you don't want to. Especially in hospital, they have the limited time that they keep in the bedside. Probably it gives a bit time. So we provide the death certificate. Uh, when patient dead, get the bereavement care, which is kind of the without the family, without the patient, right? The patient family have to grieve of the loss. So you got to really, sometimes we have to attend the funeral. So physician usually attend or not. This up to you guys. Follow up, bereavement care, and the other medical matter you got to assist with that. Okay, so any questions? I think I probably stopped you a little bit over. So this is a website that I tell you, okay, this is the first page, you can get more than 300, the kind of the quick cheat sheet that, like 1 or 2 pages, very helpful. If you want to get some answer, you can get from them. All right. So I'm ending my presentation now. Any questions?
Thank you, Sia. There is a question that how do we deal with denial of patient after disclosing the bad news?
Can you repeat that bit? I can't tell.
Yeah. How do we deal with denial of patient after disclosing the bad news? Refer to specialist or psychiatrist.
Well, a lot of times they say that, patient denial, family will denial. So I usually, give some time, they let them see the changes that they might observe during the dying process. So yes, there's a patient, the family, they always have the hope and this and that. But sometimes I show them that, the what is the actual nature of the objective finding. Let's say, so if I have the imaging or something like that, I show them. Okay, so the like scan or CAT scan, PET scan, whatever I show them, this is how extent of the disease, then actually if not, you can save everybody. Okay, so just if they're not time yet, so let it go and then talk again later. Okay, so that's how I will do.
Thank you, Sia. Another question is mine. I want to know how long is the golden glow that dying patients usually have?
Usually about 1 or 2 days, probably sometime they kind of glow up, you know. It's a foolish actually. I'm telling you, just kind of sometimes okay, I thought, you know, I made a mistake or something, but you know, but after a few, you know, 1 or 2 days, they decline again. So they are in the dying phase, you know. You have the that kind of, you know, situation happen. So especially somebody who the loved one come back, you know, they might be waiting. Sometimes, you know, you might heard about the, you know, story.
Yes.
They're waiting for someone, and then, you know, they pop up. They might be you know, glow again, and then, you know, go die again, right? So yeah, I can. This happen, you know. It's a couple of times a year. I think I've seen that.
Thank you, Sia.
Yeah.
And there's another question regarding patient autonomy in our country. We often encounter situations where a patient's family member doesn't want the patient to be informed about their diagnosis, like
Yeah.
cancer. How should we handle this kind of situation? This is a very complex and sensitive ethical issue that many medical professionals face.
Yeah, it's a different cultural background also, you know, you know, ethical principle that, you know, there's a four ethical principle, right? So the respect for autonomy, non-beneficent, beneficent, and the justice, right? So we always, you know, talk to the patients, you know, whether they want to be disclosed or not, you know, you tell them. But you got to be sensitive with the family. Otherwise, the family may be very upset, you know, you probably don't want that either, right? So I probably, you know, get the shared decision making that, you know, okay, you know, they need to know. Of course, you know, they have to kind of persuade them. If not, you know, I can't really, um, we have a situation like that too, but, you know, over time, if you get enough time, you know, they come around. Okay. So just time me in, maybe you know, you're gonna wait for them to come around. Okay. So,
Thank you very much.
yeah.
Is there any other questions? You can open your mind and speak out.
You can talk to me. That's fine. No problem. Just,
Okay. Thank you, Sia and Kim Maung So. Thank you for your enlightening talk.
okay.
Yeah.
Okay.
And
Very good.
တက်ရောက်လာကြတဲ့ဆရာဆရာမများအားလုံးဒီနေ့ webinar care at end of life အရန်ကောင်းပါတယ်ဆရာကျွန်တော်တို့ GP အတွက်ရောအများကြီးဒီ end of life care မှာ GP တွေဘာတွေလောက်ရမလဲဆိုတာအများကြီးပြသွားပါတယ်အခုဒီနေ့မတက်လိုက်တဲ့ဆရာများကျွန်တော်တို့ GP web page မှာအဲ video YouTube video ကို